Okay, hello there. I'm Dr. Thomas Martin from the University of California, San Francisco. And I'm here with Dr. Love, and we're going to talk about current and emerging therapeutic approaches for multiple myeloma. And what we're going to talk initially is about newly diagnosed multiple myeloma. There's been incredible amounts of new data presented in the last 6 to 12 months. And really, I want to focus on 6 trials: the Perseus trial, the GMG HD7, the Ischia trial, the GMG concept trial, the EMROSE trial, benefit trial, and actually, I'm going to throw in a little bit on the Maya trial, an update also. And these are patients who are transplant eligible and transplant ineligible getting frontline therapy. And I think we finally have an answer of what we should do for frontline therapy for the majority of patients with multiple myeloma. So we've seen quite a bit of data on the use of quadruplet-based therapies. Typically, it's an IMiD, a proteasome inhibitor, and dexamethasone, our classic VRD, together with a CD38 antibody. And the randomized trials that I'm going to go over mostly compare a CD38 plus VRD versus VRD, with some differences, which I'll describe. But the first is the Perseus trial that we'll talk about. And Perseus basically was a randomized large trial done by the EMN. It was in newly diagnosed multiple myeloma patients who are transplant eligible. And this was presented both at ASCO this year as well as at EHA. And in the design, patients were randomized to either receive DARA VRD versus VRD as induction. They got a single autologous transplant. They had a couple cycles of consolidation with the patients receiving the CD38 continued on CD38 consolidation. Those getting VRD just continue with VRD. And then patients went on to receive maintenance-based therapy. So there was a single randomization at the beginning. So patients who got the DARA arm got DARA in induction consolidation, and then as maintenance, DARA and lenalidomide as maintenance. And maintenance was ongoing, except at 24 months into maintenance of DARA and lenalidomide. If the patients were MRD negative, then they could actually stop the CD38 antibody and would continue just lenalidomide. If they were MRD positive, they continued on doublet maintenance. The control arm of VRD, transplant VRD consolidation, and then our maintenance continued lenalidomide maintenance until progression. It was at 10 milligrams. And those patients never received a CD38 antibody. That was very similar to the determination trial. And as you can imagine, with all myeloma trials, more always seems to be better. So for those patients who got the quadruplet versus the triplet, they had a 48-month PFS of 84% versus 68% in the control arm, and a big difference in the patients achieving MRD negativity. If we look at to the right, overall and sustained MRD negativity rates, they're actually almost double in the quadruplet arm versus the triplet arm. And so the quadruplet produced very deep and looks like durable remissions. And this is really a dramatic response in my mind. For transplant eligible patients, this really is the standard of care for us going forward. Now, we have other studies to talk about. And one of the ones that was basically updated by Mark Robb was the GMG HD7 trial. And this was a trial that used a similar strategy of quad versus triplet, but used isatuximab as a CD38 antibody versus daratumumab. And it was so isatuximab RVD versus RVD. Again, single, or some patients actually received tandem transplant. And then they went on to a second randomization at maintenance. The second randomization was to randomize patients in the maintenance portion to either lenalidomide alone or lenalidomide plus isatuximab. So because it's a dual randomization, it sets up 4 arms. One arm that will never see CD38 antibody, one arm that sees CD38 antibody throughout the therapy, and then 2 arms. One gets it in induction, and the other gets it in maintenance-based therapy. So this is a really important study for us. But this was an update just on the primary endpoint, and the primary endpoint was achievement of MRD negativity. And if you look at patients achieving MRD negativity, you see that it strongly favors those getting the quadruplet versus the triplet. And basically, this study again supports the fact that quadruplets are better than triplet studies. We don't have the data yet for the second randomization and maintenance, but this again, in my mind, proves the point that a quadruplet as frontline is better than a triplet in terms of induction followed by transplant. The deeper response and an MRD negativity rates being much higher. During this interim analysis, they looked at who are the patients that achieve MRD negativity, and you can see that the patients who are on the quadruplet arm had more patients who basically converted to MRD negativity after induction, after transplant, and then during the maintenance phase, although we don't have a lot of data for the maintenance phase at this current time. We also saw data at ASH of this past year of a trial called the Ischia trial, and this was a combination of looking at a quadruplet of isatuximab with carfilzomib, lenalidomide, and dexamethasone versus carfilzomib, lenalidomide, and dexamethasone. And there's a lot of debate what was the best triplet for induction in transplant eligible. Was it VRD or KRD? We've never had a randomized trial, but this was a randomized trial in transplant eligible patients looking at a quadruplet of CD38 plus KRD versus KRD. Again, they received induction, 4 cycles of induction, single autologous transplant, 4 cycles of post-transplant consolidation, and then they received light consolidation for a year thereafter, followed by maintenance. And in this study, there was only a single randomization. So those who got the CD38 at the beginning continued CD38 throughout the treatment. And they assessed MRD negativity throughout the trial. And what they found, again, is a markedly improved achievement of MRD negativity in the patients receiving quadruplet therapy versus those getting triplet-based therapy. And probably in my mind, the most impressive thing was to look at the patients who had what we call very high-risk multiple myeloma or ultra-high-risk multiple myeloma. Those that have 2 high-risk cytogenetic abnormalities on the far right here, looking at those patients achieving MRD negativity at 10 to the minus 6 and also at 10 to the minus 5th, showing at 10 to the minus 6 a more than 2-fold improvement in MRD negativity rates. So really a very deep response when you use a CD38 plus carfilzomib, lenalidomide, dex as frontline-based therapy in the transplant-eligible population. So we also had data from Katja Wiesel's group from Germany. This is the GMG concept trial. This was for transplant eligible and transplant ineligible. It was actually just using quadruplet-based therapy. Those who were transplant eligible got quadruplet transplant, quadruplet consolidation, and then ISA, carfilzomib, and lenalidomide maintenance for over 2 years. Those that were basically transplant ineligible received 8 cycles of induction of ISA KRD, then 4 cycles of ISA KRD consolidation, and then again, over 2 years of ISA KR maintenance-based therapy. So it was a long trial, a long administration of frontline-based therapy, but this was meant to be in patients who had high-risk multiple myeloma. And what we saw was very high overall response rates and very high achievement of MRD negativity. And that was both in the transplant eligible as well as the transplant ineligible population. Again, showing deep and durable responses in patients who had high-risk multiple myeloma. I think all these data support the use of quadruplet-based therapy as frontline therapy in the transplant-eligible population. I don't think there's any question right now of what to use as frontline. It's a quad at the current time. Now, what we saw for the first time at ASCO and at EHA this year was data from transplant-ineligible patients, a randomized phase 3 trial. It was the EMROSE study, looking at the quad versus a triplet in transplant-ineligible patients. And this was presented by Terry Facone. In this EMROSE study, it was isatuximab VRD versus VRD in patients who had newly diagnosed multiple myeloma. I'll just point out some caveats. The patients received basically 4 6-week cycles of induction-based therapy, so 24 months of induction, and then went on to receive continuous therapy. The continuous treatment in the isatuximab arm was ISA-RD, that was maintenance. Maintenance in the VRD arm was RD, and that was until disease progression. Now, I'll point out that after 18 months of therapy, patients went on to receive monthly administration of isatuximab, and that was a new thing for isatuximab trials. And what we saw for the primary endpoint, which was PFS, a markedly improved PFS, 60-month PFS of 63% in the quadruplet arm versus 60-month PFS of 45% in the VRD arm. So marked improvement. And if we look on the far right, the MRD negativity rates, it's actually doubled the sustained MRD negativity rates in patients receiving quadruplet versus triplet-based therapy. For me, these patients, these are less patients transplant eligible less than age 80. These patients, some of them did not elect to undergo transplant. So it wasn't just mainly a transplant ineligible population, but it was transplant either people who did not want to go on to transplant or people who were ineligible for transplant. Wasn't particularly, in my mind, the most frail population, but this is a large patient of myeloma, large population of myeloma patients. Again, I think even in the transplant ineligible or patients who don't want transplant, a quadruplet is definitely better than a triplet in my mind for frontline based therapy. So one of my favorite trials is the BENEFIT trial. And this was presented by the IFM at EHA. And this trial actually was also a randomization of quadruplet therapy versus triplet, but the quadruplet was ISA VRD, and the triplet was ISA RD. So isatuximab, lenalidomide, and dexamethasone. And the difference in the arms is whether or not bortezomib was added to the therapy. So this is different than the other quad-based therapies. The triplet was different. Now, we know from the original Maya study that daratumumab, lenalidomide, and dexamethasone had one of the longest PFSs. So this, in my mind, was going to be a very interesting trial. And I actually was betting on the triplet, but that's why you do the studies. And so this is a randomization 1-to-1 to quadruplet versus triplet-based therapy. This was transplant ineligible, newly diagnosed multiple myeloma patients. And they received standard isatuximab weekly for 4 weeks, and then every other week up to cycle 18, and then it was monthly thereafter. The big difference in this, in the ISA VRD arm, the bortezomib was given weekly, 3 out of 4 weeks. And so it wasn't twice weekly, it was weekly bortezomib. And obviously in the ISA RD arm, there was no bortezomib whatsoever. And the key primary endpoint was MRD negativity, and they also had multiple secondary endpoints. So if we look at the primary endpoint of MRD negativity at 18 months, it was 53% in the ISA VRD arm, and it was only 26% in the ISA RD arm. So the MRD negativity rate was doubled in the quadruplet versus the triplet. I thought a pretty amazing, actually, results. And if you look at one of the secondary endpoints, and that's MRD complete remission rates, you'll also see at 10 to the minus fifth, 37% of patients achieve that at 18 months in the quadruplet arm and only 17% in the triplet arm. And it was as impressive also in the 10 to the minus 6 MRD negativity group. So very impressive results of a quadruplet using weekly bortezomib versus the triplet of CD38 plus lenalidomide and dexamethasone. Now, you see there's better overall response rates in the quadruplet versus the triplet, and actually deeper response rates. So more patients achieving complete response and more patients achieving a VGPR or better. Now, you see the preliminary PFS curve on the right, and there's not much difference. It's 85% for the quad at 24 months versus 80% for the triplet, but this is immature. The follow-up is only 23.5 months. And I think over time, these curves will separate and will show a benefit for the quadruplet therapy. Again, showing that quad therapy, even in transplant ineligible population, is actually very good therapy. And what what I didn't tell you, but what they showed is that the peripheral neuropathy in the study was quite low. In fact, only 21% of the patients had grade 2 or better or higher peripheral neuropathy in the quad group using weekly bortezomib. So I really like this study, one of my favorite studies of the meeting. I'll just mention two other newly diagnosed ones. First, determination trial showing this was presented by Jeff Zonder at ASH, just showing a little bit about diversity. This was from the determination trial. Determination trial enrolled one of the most diverse populations for a frontline study. They had 18% of African American patients in the study, really one of the highest numbers, which is a great effort by everybody. But it was interesting results in the African American arm group, the subgroup. The patients receiving RVD alone versus RVD plus transplant, the median event-free survival was very similar, 47.7 months versus 48.2 months. Really no difference between the two. So there's no difference using transplant in that population. And the odds of achieving a complete response were greater in those getting the triplet RVD no transplant, RVD alone, versus those getting RVD plus transplant. So this speaks to the fact that we need to enroll diverse patient populations in our trials because there might be differences in the way patients respond. And so I really like this presentation by Dr. Zonder, and I think this just builds on what we need to do in the future. So conclusions for the up frontline newly diagnosed multiple myeloma. Number one, CD38 plus VRD quad therapy. It should be our new standard of care, both for transplant eligible and ineligible patients. The responses appear to be durable. Right now, the projected progression-free survival is greater than 80 to 90 months in both transplant ineligible and transplant eligible patients. So dramatic lengths of the first remission. And again, in the transplant ineligible, the benefits trial showed that weekly bortezomib was very well tolerated and effective. It's unclear in the transplant eligible whether we should be using weekly bortezomib. It's also unclear of where the benefit of CD38 is. Is it in induction? Is it in maintenance? Do you need to use both? That's still a big question. High-risk myeloma appears to benefit from quad therapy. I didn't show you a lot of the data, but in all these studies, the high-risk patients did extremely well, especially in the ISKIA trial, where ESA-KRD showed improved MRD negative rates in those who had high-risk cytogenetics, and especially those that had double hit abnormalities. And I do think over time, our newly diagnosed myeloma trials should further assess differences based on diversity.
Could I just ask you about the diversity thing a little bit?
Please.
I started hearing about this last summer from Dr. Richardson, and I've been trying to figure it out ever since then. I don't know how deep you've gotten into the whole thing, but one thing is, anything about the Duffy-Knoll connection there, and how that would explain the difference?
So he did, that's interesting. I will say that I'm not convinced that it's a Duffy-Knoll issue with this, whether there's more toxicity or whether there's more benefits in the non-transplant group, based on Duffy-Knoll. I do think that the genetics of the immune system, for me, the genetics of the immune system is much different depending on the population or the subpopulation that we're looking at. And here you see that in newly diagnosed myeloma, perhaps transplant, which may actually not be so based on the immune system, where the rest of VRD, lenalidomide maintenance, perhaps may have a better, a better immune component to it. I don't know. It's very hard to say. I will say that in some of the preliminary data from our immune-based therapies, especially bispecific antibodies, the African American population appears to be doing better, appears to have higher overall response rates. And so there is something about a difference in the immunity in these groups.
Well, also, I never really got clear, clinically, what the deal is. So, for example, if you look at African American people diagnosed with, transplant eligible versus non-African American, like, do they respond better to systemic treatment, to induction, or not as well?
Yeah, we don't really have great data on that. I think the biggest issue in diversity is um, we always said that the access to good care and the access to getting triplet-based therapy
Absolutely.
was really the difference. That it was more that unfortunately, the patients who are more challenged financially, more challenged with traveling to the academic center, et cetera, those patients were often treated with a doublet versus a triplet and never received what we would consider good standard of care therapy, and that was the difference. But I think some of these emerging data may suggest maybe it's not all that. Maybe there is true differences in the way these patients and these subpopulations are going to respond to these initial therapies. The problem is we don't really have enough diversity in our trials to really tease out what the difference truly is.
Yeah, I think that was exactly why I thought it was so amazing to see that it wasn't access, which everybody always writes off. But anyhow, I'm still curious about the whole thing. But anyhow, please continue.
So the last data that I'll update you on is the presentation by Terry Facon at EHA this past summer, looking at the final overall survival results of the MAIA phase 3 study. Again, this was daratumumab, lenalidomide, and dexamethasone versus lenalidomide and dexamethasone. And what the investigator showed is with a median follow-up of 7.5 years, that DARA-RD continued to demonstrate a very significant survival benefit. And this is overall survival benefit versus RD in patients with newly diagnosed myeloma. And the median overall survival actually was about 7.5 years. So median was 90.3 months. And I'll remind you that more than 40% of these patients actually were over age 75. So this is a really good overall survival for newly diagnosed patients receiving a triplet-based therapy. And the MAIA study, I think, brought us to using CD38s as frontline therapy. And I think nowadays we're using CD38 Lendex plus bortezomib, so our quad-based therapy. Okay, so now we're going to talk a little bit about relapse and refractory multiple myeloma. I'll show you some updates on IKEMA and ICARIA. We'll talk a little bit about the Boston trial, and then talk a little bit about the new cell mods, specifically on mezigdomide, early data with mezigdomide, and then the last, what I considered the comeback kid of EHA and ASCO, and that was belantamab in the DREAM 7 and 8 studies. So we did the IKEMA study several years ago now, and we just updated the results. We published these data late last year. We looked at progression-free survival of the triplet of ESA-KD versus KD in patients had early relapse multiple myelomas, 1 to 3 prior lines of therapy. And we showed one of the highest PFS rates of right around 36 months for the triplet of ESA-KD versus KD. I think now that this triplet is actually, one of the ones that we go to as part of our standard of care for first or second relapse, especially in patients that have not received a CD38 antibody-based therapy for frontline-based therapy. In the update, we showed very high rates of achieving MRD negativity. It was 33% in the ESA-KD arm versus 15% in the KD arm. And for MRD negative CR, it was 26% versus 12%. So very deep responses, which is really nice to see in this relapse refractory setting. We also looked at time to next therapy. And if you look at time to next therapy, although the PFS was 36 months, in fact, it was about a median of 45 months before patients went on to receive their next therapy. So in fact, they almost went 4 years before they had to switch from ESA-KD to the next line of therapy. So pretty dramatic. And you look on the right, you look at progression-free survival 2 or PFS2, and you see there was no negative connotation of receiving the CD38 KD therapy as part of early relapse therapy. The PFS2 median PFS was 47 months, and it was actually better than the control arm of KD. So again, in my mind, if you don't use CD38 therapy as part of induction therapy, it should be used very soon in relapse refractory therapy, either as first relapse or second relapse. As soon as you can introduce the CD38, in my mind, the better. We also saw an update from Paul Richardson on the ICARIA trial, and this was ESA PD versus PD. This is some final results. We look at overall survival. There was a survival advantage for ESA PD of 25 months versus 18 months in the PD arm, the pomalidomide and dexamethasone. And if you look at median PFS2 on the right, you see that PFS2 again favors ESA PD versus PD. There was no negative impact of using the CD38 soon into relapse therapy. And that's, you can choose, in my mind, you can choose a CD38 plus a PI, or you can choose CD38 plus an IMiD, pomalidomide, and both actually have good results. The data, these are different populations, but the data shows the longest PFS with ESA KD or with daratumumab KD, but you could choose either in my mind. We also looked at the time to next therapy with ESA PD or from the ICARIA study, and you saw it was 15 months versus 9 months. And then if you looked at subsequent therapy on the right side of this slide, you see that, in fact, those patients who got pomalidomide and dexamethasone, they could get daratumumab subsequently to this regimen, and they did fine because they hadn't seen prior CD38-based therapy. So they had response rates that were in the 40%, et cetera. But if you had received isatuximab PD and then you went on to receive a daratumumab combination, the response rate wasn't as good. It dropped from in the 40% range into the 25% range. So using CD38 directly after CD38, probably not a great strategy. Now I want to talk briefly about the Boston trial. We saw an update of the Boston trial looking at a median follow-up of 28 months. The Boston trial was a randomized phase 3 trial, again, 1 to 3 prior lines of therapy of weekly selinexor, weekly bortezomib and dexamethasone versus twice weekly bortezomib and dexamethasone, or standard VD therapy. And what they showed in this update was basically all subgroups seemed to benefit from the triplet versus the doublet, but there were some specific groups that did actually quite well. And you look in the PFS curves, the lenalidomide refractory did better with selinexor VD versus VD. But the PI naive, those people who hadn't received a prior proteasome inhibitor, or the bortezomib naive patients, those patients actually did really quite well, had a PFS of 29 months versus about 10 months in the VD arm. And so that's actually a nice regimen if patients have not received a proteasome inhibitor. That SVD is actually a nice regimen. It's a fairly convenient regimen. Actually, with weekly selinexor or weekly bortezomib, it actually was very well tolerated. And if you look at patients who had 1 prior line of therapy, they also did quite well. Now, these data were also updated by Dr. Jagannath, looking at the importance of dose adjustments. Selinexor is not a drug that you can give and say, come back in 4 weeks and we'll start your next cycle. You have to see how they're doing, and you have to dose adjust based on their side effects. And this shows the importance. And so this is the trial had 195 patients on it. 65% of the patients required a dose adjustment. So again, you have to actively manage these patients when they go on. But if you do, they can stay on therapy. And the median selinexor dose was 71 milligrams or 70 milligrams per week. So they actually got a fair amount. It was close to what the target was, 80 milligrams throughout the study. Those who had a dose adjustment had a PFS of 16.6 months. Those that did not have a dose adjustment had a PFS of 9 months, meaning if you dose adjust, patients can stay on longer and they will continue to benefit from that therapy. And you see the overall response rate was also 82% with dose adjustments, with only 67% of the patients did not have a dose adjustment. Again, The critical thing is when you put somebody on selinexor in a combination-based therapy, you do have to watch them closely and dose adjust and dose, either hold the dose if they're having toxicity or decrease the dose from 80 milligrams to 60 milligrams weekly, et cetera. Now, the next thing I want to go to is I want to talk about the novel cell mods. We all think the novel cell mods are our next really big class of medications that we're all getting excited about. And Dr. Richardson just published these data from the original phase 1/2 study of mezigdomide and dexamethasone in the New England Journal of Medicine late last year. This is a phase 1/2 study. There was 77 patients in dose escalation and then 101 patients treated at the recommended phase 2 dose. And I've highlighted in red on the left the overall response rates. These are heavily pretreated patients. These had 5 or more prior lines of therapy. If you look at the overall response rates of mezigdomide and dexamethasone in dose escalation, it was about 25%. But if you looked at the recommended phase 2 dosing, the overall response rate was actually 41%. Very respectable overall response rates. And these patients, especially when they got to the dose expansion cohort, the phase 2 point, 100% were IMiD refractory and 100% were triple class refractory. Now, the majority of patients got VGPRs, PRs or VGPRs in there. There was not as many CRs. But again, this is doublet-based therapy where patients who had very heavily refractory disease. Now, when you have a drug that actually has good responses as a doublet, singlet or a doublet, then you go on and you start combining it with all the other myeloma therapies. And so Dr. Richardson presented these data at ASH last year, looking at the combination of mezigdomide with daratumumab and dexamethasone. And they looked at 3 different subcohorts, B1, B2, B3, and it was just different dosing of mezigdomide, whether to give it 3 out of 4 weeks, whether to give it 2 out of 3 weeks, or whether to give it 1 week on, 1 week off. They're just testing these doses. They also combined it with elotuzumab and dexamethasone, which I'm not going to talk about much. But if you look at the data for the triplet of mezigdomide, daratumumab, and dexamethasone, this was in patients who had 2 to 4 prior lines of therapy, and a fair number of them were IMiD or lenalidomide refractory. You see the overall response rate was actually quite good in all the subgroups, with a combined overall response rate of about 78%. And you can see in the swim lane plot that a lot of these are durable. Now, this study, obviously, these patients, some of them have only been followed for 6 to 12 months. And so this needs further follow-up to really select the best subcohort, but shows that this combination is really impressive. And what I will also say about the combination is that if we look at what else does mezigdomide do with daratumumab, it also works as an immunostimulatory regimen. It stimulates the immune system. And here's data from Dr. Richardson that presented it at ASH last year. And also on the right, some additional data from Michael Emantangelo looking at the PK and PD of this combination, showing increased activity and proliferation of NK cells, increased activated CD4 T cells, an increase in effector memory T cells, and patients with this therapy showing MRD negative responses. Again, this is in very heavily pretreated patients. So this is a very active regimen, and we're looking to see which is the best combination here. And this is definitely, mezigdomide definitely has a big future in my mind in the treatment of relapse refractory multiple myeloma. I also want to talk about the comeback kid, and that is belantamab. And that was based on 2 studies that we saw at ASCO and EHA, and that was the DREAM7 and DREAM8 studies. In the DREAM8, both of these are large randomized phase 3 studies. In the DREAM8 study, it was a randomized of belantamab, pomalidomide, and dexamethasone versus bortezomib, pomalidomide, and dexamethasone. So this is triplet versus triplet, belantamab versus bortezomib. And these patients basically were randomized 1-to-1, 300 patients randomized. And I'll cut right to the chase. The primary endpoint was PFS. And what the PFS showed is a significant benefit for belantamab, pomalidomide, and dexamethasone versus pomalidomide, bortezomib, and dexamethasone, where the 12-month PFS was 71% with BPD, and it was only 13 months with is 51% or 13 months with bortezomib, pomalidomide, and dexamethasone. So this was a very dramatic, response. And it looks like the PFS may actually approach three years. This is very similar to what we saw with the IKEMA, one of our best studies in early relapse refractory myeloma. And I will tell you that these patients, a fair number of these patients actually were lenalidomide refractory. You see an improvement of overall responses, and you actually see deeper responses. More patients achieving complete response in BPD versus PVD, and more patients achieving a VGPR or better, again, in the BPD arm. Pretty impressive. There's also an early overall survival trend. And this actually needs further follow-up for us to talk about overall survival, but I just showed that, out of interest. The second study, the DREAM7 study, was actually belantamab bortezomib index, so BVD, versus daratumumab bortezomib index. So it was really belantamab versus daratumumab with VD as the backbone. So a very interesting study. Again, we saw a higher overall response rate in patients receiving belantamab bortezomib index versus daratumumab bortezomib index, higher CRs, higher VGPR or better rates, and a marked improvement in PFS. So the 18-month PFS was almost 70% in the belantamab arm versus 43% in the daratumumab arm. And again, the median PFS looks like it's going to be just over 3 years. A pretty dramatic PFS. I will say that this regimen was also convenient because it was the bortezomib dosing continued for about 8 months and then stopped. But then after that, the belantamab dosing needed to be dosed. There needed to be a number of dose holds and dose reductions. This slide shows when the dosing actually occurred. You see, initially it was every three weeks, then it went to every 6 weeks, then it went to every 11 or 12 weeks. And in fact, so there wasn't actually a patient that received this continuously every 3 weeks. In fact, most of the patients received maybe 4 to 6 doses in a year. So it's a very tolerable regimen. The reason they had to have dose adjustments is obviously because of the ocular toxicity. There was significant ocular toxicity, and we know that happens, and you have to watch them very closely in the first 4 doses of belantamab, and after that, you can make your dose adjustments, and most of the patients after that time can continue on the therapy. The reason the PFS is so good with this study and the reason the duration of response was so good in this study is because they were able to stay on therapy. They didn't have to stop it because of ocular toxicity. And so with that, I will actually conclude. I'll conclude by saying a few things in terms of the relapse refractory setting. Number one, the IKEMA study or CD38 plus PI carfilzomib, very active regimen, and I think right now is the regimen that we all go to in early relapse if patients haven't received a CD38 based therapy. Frontline, you could also choose CD38 plus pomalidomide. Selinexor and bortezomib index in patients that are PI naive certainly shows impressive results with a PFS approaching 3 years. Mezigdomide combinations, they're also showing promise, especially mezigdomide, daratumumab, and dexamethasone, both for its direct anti-myeloma effects, but also the way it actually stimulates the immune system. And we really want to see combinations of that with some of our new novel immunotherapies. And finally, the comeback kid, again, is, in my mind, is belantamab, and the triplet of belantamab is looking quite great. Now, how we're going to incorporate all of these combinations going forward in the relapse refractory space, and how we're going to incorporate CAR T cells and bispecific antibodies really is going to be, an interesting thing for us to figure out over the next 3 to 5 years.
I'm trying to compute. It was DREAM7 that was daratumumab, and DREAM8 was versus bortezomib, right? Is that right?
Correct. It was belantamab versus bortezomib and belantamab versus daratumumab.
I just can't compute how it could be better than daratumumab. That doesn't.
So it's very interesting in this study. So, yeah. In the CASTOR trial, which was daratumumab, bortezomib index versus bortezomib index, the PFS was about 17 months in that phase 3 trial. That's what gave daratumumab, bortezomib index approval, that triplet approval over bortezomib index. Now, this study, the PFS was a little shorter in daratumumab, bortezomib index, not that much shorter, but it's certainly belantamab, bortezomib index being 3 years was more than twice as long of remission duration. So it is actually quite impressive, actually.
I don't know. To me, it's more than quite impressive. It's just like I can't compute it, right? I mean, to me,
So it is,
daratumumab is one of the most effective drugs that we have in myeloma, right? And now we're talking about a drug that in the past was kind of considered as a late line. To me, did you see a lot of? I did a video with a woman who had been on belantamab for 4 years. Did you see a lot of responses clinically when you used it?
so back when we had belantamab approved for use in the United States, I actually had a fair number of patients that were on belantamab, and the dosing of it is what's been most convenient, meaning you can give a dose and patients will not get any ocular toxicity if you only give one dose and wait 2 or 3 months or 4 months before the next dose. So I had multiple patients that were just coming every 3 months or every 4 months and just getting one
But you,
dose. And then,
but you're
and
saying
that was it.
you did, but you were doing that because they had eye issues, or because you were just doing that?
You do have to dose adjust belantamab. There's no doubt about it. Majority of patients are going to have some ocular toxicity. And when they have that ocular toxicity, you either have to lower the dose or lengthen the
Right.
treatment
But I'm
interval.
just saying,
Most of the time,
but you would,
yeah.
but you wouldn't do that unless they had some kind of toxicity, ocular. You wouldn't just decrease the dose, or would you?
Um, so I actually think if patients with in the first 2 cycles have a dramatic response and their myeloma goes into remission quite quickly, I don't think there's any real reason why we need to push and give another dose 3 weeks later or 4 weeks later or 6 weeks later. I think you could actually hold the dose probably for 2 to 3 months before you give them their next dose. And so, yes, my plan is those that have an early response, they won't get their next dose for 2 to 3 months.
So again, excuse my naivete. So this was just presented for the first time at EHA. It hadn't been presented before.
ASCO and EHA, yes.
And so, are there trials incorporating belantamab at first line?
There are actually, and so there has been some data presented um, by the Greece group, and the data looks good with combination with lenalidomide and dexamethasone. But as you can imagine, there's going to be now many different combinations. And in fact, one of the Storm trial combinations now that I didn't talk about in relapse refractory, but one of the combinations was selinexor, belantamab, and dexamethasone. So we're going to get combinations of all these drugs. So yes, there's many combinations ongoing.
I don't know. To a simple person like me and people outside of myeloma, I can't compute it. It's just like hard to. It's hard to compute. You have a drug that most people look at as, I don't know if it's. I mean, you tell me. Do you think daratumumab, their anti-CD38, I should say, is the most effective agent we've had added to the regimen? I mean, is it more? Do you think it's adding more than a proteasome inhibitor or lenalidomide?
So I would say I do think it's maybe slightly more efficacious than the other classes, but the truth of the matter is it's the combination that has the best effect. That's why we're seeing such dramatic responses as quads in frontline therapy. So I do think you need to use all of those drugs together. But whether belantamab is a better or more potent drug than daratumumab certainly is a question. whether it's going to be as good in frontline as it's showing in this early relapse, hard to know. The hard part about belantamab is the toxicity, the ocular toxicity is difficult for some of the patients, whereas a CD38 antibody is pretty well tolerated for almost everybody. So we certainly will use CD38, in the frontline setting. I think belantamab may actually be a great drug for the patients who are not CAR T cell eligible or are not BCMA targeted therapy eligible, and that belantamab will take up that space either with bortezomib and dexamethasone or pomalidomide and dexamethasone. So bortezomib is going on off patent soon. It's going to be very cheap, especially outside the U.S. I think the belantamab, bortezomib, and dex combination outside the U.S. is going to be used a lot.
What about belantamab and daratumumab or belantamab and isatuximab?
Yeah, those studies are going to be done, yes.
One other question, because again, I'm just trying to process this. What would come first? I mean, theoretically, putting aside, regulatory issues, what comes first, belantamab or bispecific? And say somebody not eligible for CAR T.
Great question. And there are different toxicities for the two. So the belantamab, it's the ocular toxicity, and with the bispecifics, it is the infectious, complications. There's a lot more infections, a lot more pneumonias, sepsis, CMV reactivation, those things. So patients have to be in fairly good shape to get a bispecific. Where I think even in frail patients, we'll be able to use belantamab therapy. So I do think there's going to be a role for both of those, and they may actually be used in non-overlapping patient populations. And I think there's substantial populations in both groups.
I mean, I just, talk to people, but to me, it kind of sounds like the ophthalmic thing is really is more of an inconvenience, or is it that major for patients?
So the hope is that by dose reductions and also lengthening the interval, that the patients who have ocular toxicity will be able to recover quite quickly and then resume dosing at a much less frequent interval. In fact, the majority of patients continued on therapy. They could continue on therapy.
Right.
There are, a small percentage, it's probably less than 5% of patients that have significant changes in their vision, greater than 220 over 200 visual acuity. In those patients, it's a real deal. That changes their quality of life at that point in time. And it's hard to really pick those patients off ahead of time. So patients have to go in knowing there's a risk that you might have some visual changes for a period of time that might take 6, 8, or 12 weeks for it to get better. And so they have to be able to get through that period of time. But it's not that a lot of patients get this ocular toxicity. It is more dry eyes, scratchy eyes, things that are manageable.